Hi everyone, we are back with another session with Hirad EP. I missed the last couple of weeks due to upper respiratory tract infection. Please subscribe and like if you find these videos helpful. We are going to continue to review the latest Afib guidelines that published in 2023. This is a part 4, and we're going to review inpatient initiation of Dofetilide as well as Sotalol. So we're going to focus on how to start these two medications that we need to admit patients for that purpose. Okay, so let's start. So inpatient initiation of antiarrhythmic agents, patients with atrial fibrillation who are initiating Dofetilide, they need to be admitted for at least a minimum of 3 days. And this is the facility like a hospital setting that you can monitor EKG, you can check for kidney function, and if there's arrhythmia or for example, most likely torsade de pointes, you are able to resuscitate the patient. So for Dofetilide, minimum of 3 days is needed. For Sotalol as well, minimum of 3 days is needed for loading and assessing the proarrhythmia and bradycardia effect of the Sotalol. But in patients with, as we discussed on the last videos, patient with flecainide and propofol, even if you want to do fill in the pocket type of therapy, it is better to admit the patient at least once and give it in the inpatient setting or monitor setting and see how the patient does and on these two medications, propofol and flecainide. But today the focus is these two medications, Dofetilide and Sotalol. Okay, let's start with Dofetilide. So Dofetilide, as you know, is a class 3 antiarrhythmic drug. It's a selective potassium R blocker, also has effect on the sodium. So it's a late sodium channel blocker as well as class 3 potassium R KR blocker. And here's around 1 to 4% risk of torsade de pointes in a setting of prolongation of QT has been reported in different trials. We put it like safer D trial that they look at 241 patients. 10 of that had a QTC prolongation, and that's the reason we do minimum of 3 days, because all of these happens in the 3 days period of monitoring the patient. Now, the maintenance dose, so initiation dose, depends on the patient kidney function level. So if you have a normal kidney function, you basically give a 500 micro twice a day. It's 40 to 60 to 250 twice a day. And if it's 220 to 40, the GFR 125 microgram twice daily needs to be given. And if it's less than 20, it's contraindicated. For Sotalol, this is less than 40. So you know that we're going to talk about it on the next slide, but the difference is you can still give dicticacin to the patients with the kidney function more than 20 cc's per minute. Of course, it's going through the kidney. Half-life is around 10 hours, and it's very important, very, very important to remember what medications are not allowed or contraindicated to be given when you are giving Dofetilide, because it's a renal excreted, and anything that affects renal transport system can increase the dose of Dofetilide and results in problems, torsade de pointes. One of the important medication I want you to remember is verapamil. No verapamil with Dofetilide. And another one that is commonly given these patients, if they have hypertension, is hydrochlorothiazide, either alone or combination. So stop hydrochlorothiazide, don't give verapamil. Also, make sure they are not taking medication like triamcinolone or Bactrim type of things for infection treatment. So this is important to remember, that the GFR less than 20 is contraindicated, and hydrochlorothiazide and verapamil should not be given with Dofetilide. So let's talk about Sotalol. So Sotalol, same thing. You need to remember that you should not give Sotalol if the GFR is less than 40. That is contraindicated. If the GFR is more than 80 cc's, you can start 40 to 80 milligram twice daily as a loading dose, and then check it for 3 days that you are monitoring the patient. Remember, if the GFR becomes less than 60, so in the range of 40 to 60, you change it to once daily. So twice daily, switch to once daily of the same dose, 40 or 80 milligram daily dosing. And the maintenance dose, you can increase the dose from 80 to 160 milligram twice daily. If the GFR is more than 60, you do it again once daily if the GFR between 40 and 60. Same thing, the kidney excretion, the half-life of the 12 hours. And from the mechanism standpoint, there's one additional thing that Sotalol provides that Ticacin or Dofetilide is not providing or not causing. That's a beta blocker effect, and that basically make the patient to have a bradycardia and have some beta blocker features like a bronchospasm if the patients have a tendency for asthma. Again, if you remember from the previous videos, there were meta-analysis that showed you have a higher all-cause mortality in patients with on Sotalol, especially patient that had a reduced ejection fraction. Nevertheless, we need to be careful about their kidney function and electrolytes and monitor them when we are initiating the Sotalol. So to keep it simple, we can go over how to initiate Sotalol and Dofetilide. So important thing is you need to initiate if you see that the patient have appropriate baseline QTC interval. For the Sotalol, if the QTC is less than 450 milliseconds, you can start. But if the QTC is more than 450 milliseconds at the baseline and the GFR is less than 40, is not recommended. This is the QTC a little bit different in Ticacin, and based on the company recommendation. If your QTC is more than 440 milliseconds at the baseline or more than 500 milliseconds with ventricular conduction abnormalities, if you have a bundle branch block IVCD, or if your GFR is less than 20 cc per minute, you should not start Dofetilide. So Dofetilide, the QTC a little bit more restricted, 440 milliseconds. In Sotalol is 450 milliseconds. So baseline kidney function for Sotalol is more restricted than Dofetilide. So initial dose for Sotalol is usually 80 milligram twice daily. Then you check the EKG 2 hours after, and if you see the QTC's got more than 500 milliseconds, you can reduce the dose, or if you reduce the dose again, and still you see the problem of increasing QT interval, you stop the Sotalol. And in case of the GFR 40 to 60, you do 80 daily. In Ticacin, it has three different cutoffs here. So if your GFR normal for 500 twice a day, if the GFR is 40 to 60, you do 250. And if the GFR is between 20 to 40, you do 125 twice daily. Then you look, if your QTC increased more than 15%, 1-5, or if you notice that the QTC increased more than 500 milliseconds, then you reduce the dose, and if you already reduced the dose, you won't give the patient anymore. So once you reduce the dose, and after that, if there's still QTC increases the delta as well as the cutoff, then you should not continue treatment with Dofetilide. This is not based on the guideline. This is a base of the paper that I placed it here. And that's about it, and thank you very much. See you next week. We're going to talk about how to follow up rhythm drugs, how to assess for their side effects, and next week. Thank you very much, and bye-bye.